Okay, good. Well, thank you all for being here this morning. I first talked about the clinical phenotype of NGLY1 deficiency at the Stanford Burnham Institute. It was a symposium put together by Dr. Hud Freeze, who is a central hub in the NGLY1 story. So it's my pleasure to be able to talk further about this condition. This is a true team effort. So Matt Wilsey has already discussed that interlocking network of individuals throughout the world. It really starts, of course, with the families, the children. The interest that has been generated has been remarkable. Duke University was the first to identify a patient with NGLY1 deficiency. Our story was linked really closely to the Baylor College of Medicine, where Matt Bainbridge was the first to link our patient with this diagnosis. We come from all over the world. Emory University has participated, University of British Columbia. We have colleagues throughout the country, and so even Germany and beyond. So it's really an integrated network that has helped put the story together. So here's the story. NGLY1 is a very interesting enzyme. It was first described by Dr. Takahashi in almond emulsion, 77. What does it? It has different names, and some people know it in the literature as peptide N-glycanase, glycanase 1, also PNGase. It is an enzyme that catalyzes protein deglycosylation. It cleaves a specific bond in glycoproteins and releases intact N-glycan species. Key cytoplasmic component of the endoplasmic reticulum-associated degradation, or ERAD, machinery. The actual bond that it cleaves is shown here. It's an amide link, and the enzyme releases an intact oligosaccharide that is N-glycose limited and cleaves the asparagine to create an aspartate derivative. The protein. So you're left with a intact protein in one case and an intact oligosaccharide on the other. Look at NGLY1 and its position in the ERAD pathway, you'll see that it's cytosolic. When proteins are synthesized in the lumen of the endoplasmic reticulum, if they are not quite correctly folded, they are retrotranslocated into the cytoplasm, where they undergo ubiquitination and further degradation with the action of NGLY1. Here it's listed as PNGase. Here's a cartoon that just shows how central it is in the ERAD pathway, really playing a key link between the ERAD machinery and a variety of different subunits that are responsible for degrading misfolded glycoproteins. So it's really part of a quality control system in which if the cell cannot break down a glycoprotein normally, it will accumulate. And we think we have some evidence of that in the patients that we first have come across. So the initial clue started with the publication of this excellent article from the Duke group, with Dr. Need being the first author and Dr. Goldstein being senior. It's an article really designed to show the utility of exome sequencing in detecting the cause of undiagnosed genetic conditions. The list of 12 different conditions, 12 different patients with rare disorders, and all these different individuals had undergone full sequencing. But we zoom in on patient number 2, and this is the link that was made by Baylor. They first identified that this NGLY1 deficiency had been reported by Duke. This, they reported a 3-year-old boy who had developmental delay, multifocal epilepsy, involuntary movements, abnormal liver function, and absent tears. Really the coalescence of features that just rang the proverbial bell. As such, that opened up a whole network, and see the network listed here, of individuals who are working on NGLY1 in various capacities, clinicians, researchers, counselors, the whole gamut of specialists here, basic research as well, very important sequencing people, Hudson Freeze. So in that article that has just been published in Genetics and Medicine, we described our experience with the first initial 8 patients that came to our. The patient's age ranged between 9 months and 20 years. 2 siblings died at 9 months and 5 years of unknown cause. 5 females and 3 males, and all Caucasian. These are the pedigrees of the initial 8 patients. You'll see that in some cases there are families with multiple affected individuals. There's one case of clear consanguinity, but in other cases there's no consanguinity that we know of. Looking more closely at the types of mutations that are involved in the initial patients, you might notice that they're all quite severe. They cause a nonsense mutation that ends up being quite a severe deficit to the protein that is coded. To describe these patients, just to get a little bit of a feel for them, so you can understand who we've been seeing. Now I feel a little bit even more close to these families, because for the first time I've actually met them. So it's quite something to see all these children at the Stanford Burnham Institute. So the first is now a 5-year-old male who had neonate involuntary movements, athetosis or writhing of the trunk, extremities, lip smacking, global developmental delay, hypotonia, intractable multifocal epilepsy that is now improved since starting valproate, and liver disease in infancy. The interesting thing about the liver disease, although it's highlighted as a feature of NGLY1 deficiency, it seems to improve with time. Fulminant, we haven't seen patients with hepatic failure. The other interesting features included cortical vision impairment, congenital alacrima, an inability of making tears, and corneal ulcerations. Patient 2, a patient from Italy, a 20-year-old female with developmental delay, hypotonia, liver disease, again in infancy. Involuntary movements were noticed by age 4 years. Also has alacrima, cortical vision impairment, and currently has very little expressive speech, ambulates with a walker, but can communicate to some degree with an electronic speech generating. This is our patient. You've heard quite a bit about her. 4-year-old female who had, as well as what was discussed, neonatal hyperbilirubinemia. We've heard about the increased liver function test, the liver disease that still seems to be grumbling on, but has not worsened. Global developmental delay, microcephaly developed, exotropia, hypotonia, constipation, especially in infancy. No tears while crying, first noticed at about 1 year. Staring spells were also noticed around that time, but no overt seizures have been. Extrapyramidal movement disorders noticed at about 17 months, in which really appeared tremulous, quite as steady as you would expect, but no severe movement abnormality. Barely strike you unless you're really watching her closely. Currently, she can ambulate but has an unsteady gait, communicates with vocalizations, gestures, and an assistive device. Active and bright when you meet her. Fourth patient is a 2-year-old male with intractable epilepsy starting in infancy. Global developmental delay, abnormal tear production, unilateral ptosis, strabismus, increased liver enzymes, and constipation were noted in infancy. Also has an abnormal sleep pattern. Crawls and communicates with vocalization. Patients 5 and 6 were both from the same family in Canada. The female died at 9 months in sleep. Died at 5 years following a febrile illness and prolonged seizure. It's unknown what the cause of death was in either children. Both had global developmental delay, a movement disorder, low muscle tone, microcephaly, increased liver enzymes in infancy. Boy developed dry eyes after approximately 1 year and intractable seizures at 2.5 years. The girl is the only one of our 8 patients who was not described having dry eyes, but perhaps this would be something that would develop in time. Patients 7 and 8 are also from the same family. They're currently a 3-year-old girl and a 16-year-old girl. Global developmental delay, hypotonia, an increase in liver function test was noted in the 3-year-old girl, but was never really checked in the 16-year-old until later on. Movement disorder developed in infancy. Microcephaly, abnormal tears, strabismus, and constipation were present in these children. They could sit and crawl at 2 years. No words present at 1-year-old. And the older girl lost all mobility at 11 years after developing seizures. So developmental delay, cognitive impairment, developmental difficulties are present in these patients, but developmental regression or sliding backwards seems relative. Had severe symptoms such as seizures, and of course in that single family, 2 patients have died. The clinical features of NGLY1 deficiency in these first 8 patients are summarized here. All have had developmental delays, all have had a movement disorder, all have had low muscle tone. 7 of 8 have had alacrima or hypolacrima. 7 of 8 have had EEG abnormalities, although 4 of them have been diagnosed as having real seizures. Constipation is also common, as is liver enzyme elevation, a small head circumference, decreased reflexes, abnormal imaging, and I'll go on and sort of go through these things in a different way. I've mentioned this already, but this is a list of relatively common clinical features experienced by most, if not all, of the patients with NGLY1 deficiency about whom we have information. Here are less common features, but still relatively apparent. Not everybody has had all tests done. You can see that, for example, elevated blood lactate was present in 4 of 6. Wilsey has already described that there's this possibility of mitochondrial involvement maybe as a secondary factor. And this is one of the things that was present in our case and seems to have really led us to think about mitochondria as well, as there was intermittent and but relatively clear elevation of lactate. Interesting, this is the finding of abnormal storage material in liver biopsy. If this enzyme is not working, you're storing things, and this is probably what we're seeing on the biopsy. Other interesting finding that we can't explain, small hands and feet. How this relates to NGLY1, but we've had that reported in the other findings on the list include abnormal nerve conduction. This was only checked in 3 patients. And interestingly, a positive second trimester screen for trisomy 18 or Smith-Lemmy cases, they had a low unconjugated estriol or and HCG, and this was present in 3 out of the 8 cases for whom we have data. Perhaps this is a prenatal clue problem here, but we don't really know what the connection is. Elevated, apparently transient AFP levels have also been detected. Not all patients have had this checked. The ones who have it checked later on in childhood were the ones with normal levels, the elevations in infancy. If you do hearing testing, abnormalities were detected in 2 of our patients, and in our patient, an abnormality that was apparently present seemed to resolve, which is very happy to hear. Liver fibrosis is also seen in 2 of the 6 cases in whom biopsy done. The brain imaging findings are nonspecific and relatively mild. I list them here. There's nothing that really cries out to me as something to on as far as trying to direct a diagnosis here, just saying that there are. Dysmorphic features have been described, and they're relatively mild. Some children have a more severe or dysmorphic appearing facial appearance, while others really hard to see these whatsoever. I list these well. Small hands and feet are the relatively common thing that has been reported, but a variety of minor findings, including frontal bossing, a metopic ridge, a mild short nose, etc. in some cases, there was some resemblance or a mild resemblance to Smith-Lemli-Opitz syndrome. Clear constellation of features that we can see as yet, so perhaps we'll need some more patients identified before we can really get a handle on it. The molecular findings in the first patients I've already alluded to are remarkably severe, remarkably similar. So homozygosity for this mutation was present in 5 patients. 5 patients share the exact same genotype, at least in relation to the NGLY1. Some of those patients have gone on thriving or living into their years. So it's not clear exactly how to make a genotype-phenotype correlation. The patients that we have seen and detected, however, looking through this list, really indicates that this is we're really looking at the most severe, I think, collection of families so far. This is a deletion. This should be a frame shift, a mistake in the slide. But this points to the fact that we're probably not detecting more mild cases as yet. Hope that with whole exome sequencing and other techniques being available broadly clinically, we're going to be able to find children with some degree of neurological dysfunction, lacrima. And in these cases, the lacrima was considered to be secondary to autonomic nervous system dysfunction. Not really sure how this relates to NGLY1 deficiency. As you might have guessed, the other disorders in the differential include mitochondrial disease, at the top of the list, congenital disorders of glycosylation. Rett syndrome and related conditions because of the seizures, developmental delay, and a variety of neurotransmitter disorders can also give you abnormal movements. So these are all considered as well and tested, and we had some patients have mild disorders, non-specific in testing for glycosylated transferrin, for example, for the CDG, but nothing specific. As far as mitochondrial disorders go, elevated lactates, sometimes abnormalities in urine organic acids, sometimes in our case we had a liver biopsy that showed a depletion of mitochondrial DNA. The specific diagnoses, but those who had mitochondrial respiratory chain analysis also sometimes mild abnormalities were detected. So just quickly in the next few minutes, I wanted to go through a couple of other reports of conditions that are associated with the ERAD process, or endoplasmic reticulum-associated degradation, because this new disorder, NGLY1 deficiency, seems to fit somewhere into this spectrum. I'm not really sure how it fits together yet, but we're starting to see other disorders that this pathway affects. The first is something called MAN1B1 deficiency. It's mutations in alpha-1,2 mannose gene causes problems in these affected individuals who have non-syndromic intellectual disabilities, subtle dysmorphic features, and this is enzyme involved in the ERAD pathway in the Golgi system. Another disorder called Erlin2 causes autosomal recessive intellectual disability that seems to be severe. Developmental regression is present. Patients have contractures. And this is a process that is also part of the quality control system in our system. Last disorder that I will mention in brief. Gene RNF170 mutations that cause a dominant condition, which the patients have a late onset sensory ataxia and diminished reflexes. And this is involving ubiquitin ligase, another enzyme important in the ERAD process. So how do all these things come together? I'm not really sure. The NGLY1 is the first cytosolic enzyme involved in this process that we know of, and links to be described and discovered yet. Last few minutes, I want to discuss something completely different. Because of the mitochondrial dysfunction secondary NGLY1. One possible approach to thinking about therapies is to look at the redox axis, to look at treatments that can involve treating mitochondrial dysfunction, which leads to redox imbalance or an imbalance of oxidative metabolism. Local company, Edison Pharmaceuticals, currently has this drug, EPI 743, in clinical trials for mitochondrial disorders such as Lee syndrome, ataxia. It's a small molecule, good oral bioavailability, crosses the blood-brain barrier, has a very favorable pharm-tox profile, and is redox active. If you look at it, EPI 743 is shown here. It's a quinone with some similar structural similarities to other quinones such as CoQ10 or debenone. However, there are some important differences as well, and really not all antioxidants are the same. If you look at a cyclic voltammogram, between top is coenzyme Q10 and here is E3, you can see there are really different electrochemical properties, although the biostructure at least shares some similarities. When you look at the partition coefficients and redox potential, you see that EPI 743 also has a very different redox potential, being offset by 75 millivolts between these other antioxidants. So a very different type of a medication in mitochondrial disorders. We have been using this agent, this is work done by Francis Blankenberg at Stanford, to measure the response of patients taking EPI 743 by looking at their brains. We think that this SPECT imaging agent, called HMPAO, is a surrogate marker for brain glutathione and hence for mitochondrial dysfunction. Here's a sample from a patient who is treated with EPI 743 who has Lee syndrome, secondary to SIRF1 mutations. And the red is the HMPAO signal. You can see after 3 months of therapy, there is an increase in overall brain signal. I think a redox active drug may have some form of a beneficial effect in mitochondrial disease. Clinical trials are ongoing. We're waiting to come up with the answers. The compelling and an interesting possibility. We're very interested in glutathione in our laboratory, and just to remind people that it's not really a simple question of balance, giving antioxidants to combat oxidative stress, but our cellular circuitry is really quite complex. I still think that the glutathione has various important effects in the cells of our mitochondrial patients, and we measure whole blood glutathione. This is showing redox potential. This is the normal controls here. Mitochondrial disease patients tend to have a redox potential that is 9 millivolts or 10 millivolts or so more oxidized than normal controls. So we're seeing some evidence of peripheral redox imbalance. I show you this as a precursor because this is what we have seen in our patient. We have 9 separate measurements of whole blood glutathione in our patient. And the redox potential is in the lines of the same as what we see with our mitochondrial process, although this is a cytosolic enzyme important in quality control systems. Somehow redox metabolism, mitochondrial metabolism is thrown out of it. Done so in a similar way that we have seen in our mitochondrial disease patients. Further studies have been done on 2 patients who have donated fibroblast skin cultures to, this is work done by Vicky Kafetz at Edison Pharmaceuticals, where she cultured the patient fibroblasts, stressed them out with a compound PSO that inhibits glutathione synthesis, and then looked for rescue by putting various drugs onto the wells to determine if any medication could rescue these cells. First, after stressing them with BSO, these are the 2 cell lines from the NGLY1 patients. These are normal controls. You can see that the NGLY1 patient's cell lines appear to be exquisitely sensitive to oxidative stress. So this is a stressor where you're looking at cell viability, and just with low concentration of a drug that will lead to oxidative injury, you get decreased viability really quite rapidly versus the normal controls. When you treat these cells with Epi743 and compare them to CoQ10 or edebenone, CoQ10 or edebenone don't seem to do much. Edebenone, you have some viability rescue at the concentration somewhere between 100 and 1,000 nanomolar. This is a logarithmic scale. But with EPI743, you have a stepwise improvement at a low concentration, which is seen in not only this line, but in both cell lines. So interesting information. We're not sure where this will lead, but Edison Pharmaceuticals has agreed to do a trial in the NGLY1 patients, and we're very excited about that, and also cautious, but cautiously optimistic. So as I've said, this is a collaboration between many different individuals. These are the folks who have been working on the NGLY1 story from across the world, and there are more local folks here working in the mitochondrial story. Collaborators with pharmaceuticals are listed here. We have collaborators around the country with us in clinical trials. And thank you for your attention.